Staying on topic with structural reasons for recurrent pregnancy loss, or RPL, we're now moving on to congenital causes. So congenital causes are generally structural variations that are there from birth. So they've occurred when the person was an embryo inside mum, and it's persisted in life. I think the important thing to understand about congenital structural issues and their link to recurrent pregnancy loss is that we don't have very solid evidence that links these causes together. What we have are what we call retrospective studies, so studies that examine events after they've happened. Ideally, we want studies that look forward, that follow somebody with a condition forward prospectively, and they're the best kind of studies. The studies that mostly look at structural issues that are congenital in nature are retrospective, that are studies that are looking back. So most of these conditions do have a link to recurrent pregnancy loss, but most of them can't be remedied. So that is doing big operations to fix these structural rearrangements, or structural issues don't seem to improve pregnancy loss rates, bar a few exceptions. So when we talk about congenital structural issues, we are talking about congenital issues with the uterus as it forms. The uterus, the fallopian tube, the cervix, and the top 2/3 of the vagina come from two tubes called Mullerian ducts. So these are tubes that exist in the embryo. In order for us to form a fully functional female reproductive tract, including the uterus and cervix, these tubes need to grow, they then need to fuse, and then they need to resorb in the middle where there is a dividing wall from the fusion. And only with these three complete processes can a fully functioning uterus, cervix, and top of the vagina exist. If there is no growth of these ducts, then there is absence of the top of the vagina, the cervix, and the uterus. So this is called complete uterine agenesis. The syndrome is called MRKH. It's very rare, and there is no treatment apart from surrogacy and also uterus transplantation. If these ducts do grow, but they do not fuse, then this is a fusion abnormality, and this is where we have essentially things like unicornate uteruses, where there's only one horn that exists, one half of the uterus as a hemiuterus that exists, or where you have two hemiuteruses, two halves uteruses that are completely separate from each other. So two cervixes, two half uteruses, two fallopian tubes that don't really communicate with each other. This is the uterine didelphys. Uterine didelphys and unicornate uteruses, so only one half of the uterus functioning, all of these are linked in some way weakly to recurrent pregnancy loss, and they are linked potentially to second trimester loss and short cervixes in pregnancy. But there is no data that suggests that fixing these problems can actually resolve this issue. Certainly in terms of weak cervixes, obstetricians can later on strengthen the cervical sutures and so forth. But from our perspective of recurrent pregnancy loss, not much can be done. Now, if you have two ducts that grow and they fuse and they don't fuse completely, then you can potentially have where people call them the heart-shaped uteruses. These are the bicornate uteruses where the fusion always goes from the bottom bit fuses and fuses up to the top. So where you have incomplete fusion is where you have the bottom bit is fused and the top bit is unfused, so you kind of get this heart-shaped or bunny ears almost. And these are bicornate uteruses. Again, same issue, small link to recurrent pregnancy loss. Can't really do anything surgically to fix it that improves things. People have tried where they've cleaved these uteruses in half and then reattached them with big operations. They're called metroplasties, and doesn't really make a difference. Now, Resorption defects are where the uterus has fused properly, but the middle band that separated out the two horns, the two tubes that fuse, that needs to dissolve. And when that middle band doesn't dissolve, this is a resorption defect. It results in what we call a uterine septum. So there is literally a piece of tissue that divides a complete uterus in two. This division can be complete, that is, goes from the top of the uterus right down to the bottom of the cervix, or it can be partial, where it goes from the top of the uterus and descends halfway down. The evidence for uterine septa are that they are linked to recurrent pregnancy loss, and there is evidence, even though it's retrospective, so backward-looking evidence, that fixing these can improve recurrent pregnancy loss rates. Now, this is extremely controversial. There is one prospective study, so one study looking forward to look at people with these septate uteruses, whether taking these out or leaving them alone makes a difference to fertility. And in fertility, it makes no difference, but there's still no study looking at recurrent pregnancy loss. And the studies we have all are retrospective or backward-looking, and these backward-looking studies do suggest that the septum has a negative impact on pregnancy loss because that piece of tissue is abnormal. It's got abnormal blood flow. The embryos implant on it, and it doesn't implant well, and it gets lost later on. And there is evidence retrospectively that taking out this piece of tissue may improve recurrent pregnancy loss. Now, to make things even more confusing when we look at congenital uterine anomalies, is that you can have variations of these. You can have partial fusion resorption defects, and you can have septa where there's also in an arcuate uterus or a bicornuate uterus. So there are combinations of all of those things which can make it very complicated. The best way of looking at things is, again, a decent ultrasound. A good 3D reconstruction can help you with identifying with most uterine defects that are congenital. Sometimes MRI is very helpful as well. In terms of fixing these defects, as we said before, there's not a lot of evidence for most of these that fixing them makes a difference. If you do have a uterine septum, then we can fix these with a hysteroscopic method, just like what we did for fibroids and polyps and scar tissues, that we put a camera inside the uterus, sometimes under ultrasound guidance, and we can then gradually chip away at this piece of tissue until it's all gone. So hopefully that's a very quick summary of congenital structural issues that relate to recurrent pregnancy loss.